Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. Today we are shifting gears a little bit.
A lot, I'd say.
Yeah, a lot. Usually we take a really broad topic, history, tech, whatever, and we explore the edges of it. We kind of meander.
Right.
But today we are focusing, we're drilling down, we are doing a dedicated cram session.
That's right. We are putting on our nursing educator hats today.
Okay.
We have a very specific mission.
Exactly. I mean, we know we have a ton of listeners who are in nurse cycle, or maybe you're prepping for the NCLEX, or even seasoned nurses who are just about to start a rotation on a PEDS unit and feel a little rusty.
Mm-hmm.
And the feedback we get is always the same. I am drowning in information. Help me figure out what actually matters.
It is the classic problem in medical education, isn't it?
Yeah.
You've got a textbook that's like 3 inches thick. You have slides from your professor. You have hospital protocols.
But an exam with 50 questions.
Right. And you cannot memorize everything. In fact, if you try to memorize everything, you'll probably fail.
Yeah.
Because you won't understand the core principles.
The Pareto principle.
Exactly. The 80-20 rule. We want to focus on the 20% of the material on adolescence that is going to show up on 80% of your exam questions.
Yeah.
And I think more importantly, in 80% of the critical clinical situations you're going to face.
So today, our patient is the adolescent. We're talking ages, 11 to 20, the transition years.
Yep.
And looking at the stack of research and textbook excerpts we have here from Wolters Kluwer, from the CDC vaccine schedules, it feels like this is the era of the shift.
That is the perfect way to describe it.
Yeah.
It's this shift from, the total dependency of childhood to the independence of adulthood. And as a nurse, your role shifts too.
How so?
You aren't just talking to the parents anymore. I mean, you are, but you're also building a partnership with the patient themselves.
But it's a dangerous time.
It's a very dangerous time. The body is changing, the brain is rewiring,
Yeah.
and the wrists change from I fell off the monkey bars to I drove my car too fast.
Okay, so here is our roadmap for this deep dive. We're going to strip away the fluff. We're going to hit the physiology of puberty, why they look so awkward, and what hormones are driving the bus.
Oh.
We are going to talk about the invincible mindset and why it is a safety nightmare.
A huge one.
We're going to nail down the tween trio, the vaccines you have to know, and we are going to cover the safety assessments that actually save lives.
No, just a quick disclaimer before we jump in.
Okay.
The source material we're using, especially the growth charts and physiological data,
Yeah.
often categorizes physical development by males and females
Yeah.
based on biological sex traits.
Yeah.
Ovarian or testicular function.
Right.
However, as nurses, we know that adolescence is also the prime time for identity formation. Our job is to provide safe, inclusive care for all adolescents, regardless of how they identify, while still understanding the underlying biology.
Well said. Okay, let's get into the nitty-gritty. Part 1, the foundation. We're talking vitals and pain assessment. These seem so basic, but I feel like this is where students lose easy points.
It absolutely is.
Yeah.
Because there's a temptation to treat them like big children, or, on the flip side, just treat them exactly like adult. They're in this gray zone.
So if I walk into a room to assess a 16-year-old, what should I be expecting?
You're expecting near adult numbers. And this is a common trap for students who have just come off a toddler rotation.
Right.
If you see a heart rate of 110 in a toddler, you're happy. That's totally normal. If you see a heart rate of 110 in a 17-year-old who's just sitting in a chair, that's tachycardia. That is a red flag.
Let's break down the why behind that, because understanding the mechanism helps it stick, right?
Sure. Let's look at the heart. The normal range for an adolescent is roughly 50 to 100 beats per minute.
50. That sounds incredibly low compared to a kid.
It is, and here's the physiology. During adolescence, the heart is physically growing in size and strength. The actual muscle mass of the heart increases.
Okay.
That means the stroke volume increases. The heart pumps more blood with every single beat.
So it's more efficient.
Way more efficient. And because the pump is more efficient, it doesn't need to cycle as fast to maintain cardiac output.
So the engine got an upgrade.
Exactly. It's like switching from a 4-cylinder to a V8. It can idle lower. Now, if you have a teen athlete, say a cross-country runner, their resting heart rate might be in the 40s or low 50s.
And that's fine for them.
That can be totally normal for them.
Yeah.
But if you have a sedentary teen with a rate of 110, you need to investigate. Are they anxious? Are they dehydrated? Are they on some kind of stimulant?
And what about the lungs? Same idea.
Same efficiency principle. The respiratory rate drops to about 16 to 20 breaths per minute. The lungs are increasing in diameter and length. The vital capacity, the amount of air you can move, it increases significantly.
And blood pressure.
We're looking for a systolic, generally less than 120, and a diastolic less than 80. But here's the high-yield nuance. Hypertension screening becomes very, very real in this age group.
Why is that? I always thought high blood pressure was an old person problem.
Not anymore. I mean, with the rising rates of childhood obesity, we are seeing primary hypertension in 14, 15, and 16-year-olds.
Wow.
So we need to be checking BP at every well-child visit. If it's elevated, we don't just ignore it. We recheck, and we start looking at lifestyle.
Okay, so vitals are basically approaching adult norms. What about pain? In pediatrics, we're always taught about, the FLACC scale or the FACES scale. Does that apply here?
For the vast majority of adolescents, no.
Yeah.
And this is a high-yield exam point and, honestly, a massive clinical rapport issue.
Right.
The gold standard for pain assessment in anyone over the age of roughly 5 to 7, and certainly for a teenager, is the numeric scale, 0 to 10.
Self-report is king.
Self-report is king. An adolescent can verbalize, they can quantify, they can describe their pain, they can tell you it's a throbbing pain versus a stabbing pain. They can localize it.
I can just imagine walking into a room with a 15-year-old football player and holding up a card with a cartoon crying face.
You have lost him immediately. You've just signaled, I see you as a baby. And in adolescent nursing, rapport is the currency of the realm. If you insult their intelligence or their maturity, they will shut down. And if they shut down, they won't tell you the important stuff later. So you use the numeric scale unless there is a significant developmental delay or some kind of communication barrier.
Okay, let's move to part 2, the biological shift. We're talking about puberty and physical growth.
The leggy phase.
I remember this phase so vividly. Just tripping over nothing. Arms feel too long for your sleeves. Why does that happen? Is it just random?
It is not random at all. It's a very specific growth pattern. In infancy, we grow cephalocaudal, head to toe. That's why babies have such huge heads.
Right.
But in adolescence, the growth reverses. It's distal to proximal.
Distal to proximal. Okay, let's unpack that.
It means your hands and feet grow first.
Really?
Yes. Then your arms and legs lengthen. And the torso grows last. So you literally have a 13-year-old boy whose feet have shot up to size 11. His legs have lengthened, but his torso hasn't caught up yet.
So his center of gravity is just shifting constantly.
Week by week, he is piloting a vehicle that keeps changing its dimensions.
That's a great way to put it.
So when he knocks over the sterile field or trips coming into the exam room, it's not just carelessness, it's his physiology.
That is actually a really helpful thing to tell parents, too. He's not just being clumsy on purpose.
Absolutely. It's anticipatory guidance. You tell them, this is normal, he will grow into his feet.
Now, exams love to ask about the timing of puberty. Who starts first?
Females usually beat the males by about 2 years. Puberty for biological females typically begins around ages 9 to 10.
Okay.
The peak height velocity, that's the absolute fastest period of growth, that hits early, around age 12.
For males.
Everything is shifted back. Puberty starts around 10 to 11, but that peak growth spurt isn't until maybe age 14. And here's the big difference. Males continue growing for much longer. Their growth plates, the epiphyseal plates, don't close until their late teens, maybe 18 to 20. Females typically stop growing much earlier.
Is there a marker for when females stop growing? I feel like I've seen that on practice questions.
Yes, this is a massive need to know. For females, linear growth usually stops about 2 to 2.5 years after menarche.
After their first period.
Right.
Oh, wow. So if a girl starts her period at 12, she's pretty much done getting taller by 14 or 15.
Exactly. The estrogen surge that causes the period also works to close those growth plates in the long bones. So if you have a 14-year-old female patient who's worried about being short and she started her period at 11, well, biologically, that window has mostly closed.
It's a hard conversation.
It's a hard conversation, but it's really important physiology for you to understand.
So what are the hormonal drivers here? We know the names, but what do they actually do?
It all starts in the brain. The hypothalamus releases GnRH, gonadotropin-releasing hormone.
GnRH, okay.
That kicks the pituitary gland to release FSH and LH. In females, this stimulates estrogen production. And estrogen is responsible for breast tissue development, the widening of the hips, pelvic remodeling for potential childbearing, and increased fat deposits.
And for males.
It triggers testosterone. And here is a specific exam detail that catches people off guard. The first sign of puberty in males is testicular enlargement.
Not the voice, not the hair.
Nope. Testicular enlargement is step 1. Then comes the muscle mass increase, the voice deepening, because the larynx is growing, and the widening of the shoulders.
You mentioned the voice deepening. That's the larynx growing.
Yes. The laryngeal cartilage grows, and the vocal cords lengthen and thicken. That's why you get the voice cracks. It's basically an instrument that is being retuned while it's being played.
That is a great analogy. Before we leave biology, let's talk about the brain. Because the body is looking like an adult, but the decision-making...
The brain is under massive construction. The myelin sheath, as the insulation around the nerves, it's growing rapidly. This speeds up processing power. They can actually think faster. But the prefrontal cortex, the CEO of the brain, the part that controls impulse and judgment, is the last part to mature. Doesn't finish until the mid-20s.
So you have a Ferrari engine with bicycle brakes.
Precisely. High drive, low control. And that leads us perfectly into part 3. The mindset. Psychosocial development.
We have to talk about Erikson. If you're in nursing school, you live and breathe Erikson. What's the stage for adolescence?
Identity versus role confusion. This is the who am I phase.
And how does that actually manifest in real life?
They are trying on different hats. I mean, one month they're into sports, the next month they're goth, the next month they're activists. They're trying to separate their identity from their parents.
Right.
This is why the peer group becomes God.
Right. Parents often see this as rebellion. They only care what their friends think.
But as nurses, we need to educate parents that this isn't really rebellion. It's a developmental necessity. The peer group provides a safe base for them to try out these identities. They can discuss things with peers they wouldn't dare tell their parents.
So if a teen wants their friend in the exam room but not their mom, that's developmentally normal.
Very normal. And, barring any safety issues, we often accommodate that, or we try to split the visit part with the parent, part alone with the patient.
Which brings us to Piaget. We're moving from concrete thinking to what?
To formal operations.
Yeah.
Abstract thinking. This is a huge shift. A younger child thinks, if I touch the stove, I burn my hand. It's very concrete.
Right. Cause and effect.
Exactly.
Yeah.
An adolescent can think, if I engage in risky behavior, it might have consequences for my future career. They can hypothesize. They can think about the future.
But there is a glitch. Because if they can think about the future, why do they do such dangerous things?
There is a major glitch. It's called adolescent egocentrism. Even though they can think abstractly, they're obsessed with themselves and how others perceive them. And this shows up in 2 main ways that exams absolutely love to test on.
Lay them on us.
First, the imaginary audience. The teenager walks into the cafeteria and genuinely believes, that every single person is looking at the pimple on their chin. They feel constantly watched and judged.
I think some of us never grow out of that one.
Probably not. And the second one,
What is it?
the personal fable. This is the belief that I am unique and the rules of probability don't apply to me.
The "it won't happen to me" syndrome.
That's it. I can text and drive because I'm a good driver. Other people crash, but I won't. I can have unprotected sex just this once. I won't get pregnant. This personal fable is the driving force behind the high rates of injury and death in this age group.
So it's not that they don't know the risks.
Oh, they know them. They can recite the risks to you. It's that they don't believe the risks apply to them.
So, as a nurse, how do you talk to someone who thinks they are invincible? You can't just lecture them.
No, lecturing fails every time. You have to treat them like a partner or a colleague. No baby talk. And the most critical tip, confidentiality.
How much
You
confidentiality?
need to establish it early. You say, what we discuss here is private between you and me, unless
There's always an unless.
you tell me you are going to hurt yourself, hurt someone else, or someone is hurting you. You have to set that boundary. But beyond those safety issues, you need them to trust you enough to tell you about the drugs, the sex, the depression.
Right.
If they think you're just going to run and tell their mom that they vape, they will clam up.
And use open-ended questions, right? Not yes, no.
Always. Never ask, do you understand? They will just nod to get you to shut up.
Right.
You say, tell me what you know about.
Yeah.
Or how do you plan to handle it if your friends are drinking at the party? Make them walk you through their thought process. It forces them to use that new abstract thinking ability.
Okay, let's pivot to the scary stuff. Part 4, the danger zone. We mentioned the personal fable drives risk. What is actually killing adolescents?
If you remember nothing else from this safety section, remember this order. The #1 cause of death is unintentional injuries, and specifically motor vehicle crashes, MVCs.
The car is the most dangerous weapon they handle.
Absolutely. It's inexperience, plus that personal fable, plus distractions like texting or having other teens in the car. It is a lethal combination.
So the nursing guidance is strict.
Very strict. Seatbelts, no texting, limit night driving, and limit the number of passengers.
Why limit passengers?
The data shows that for every additional teen passenger in the car, the risk of a fatal crash goes up exponentially. It's the distraction factor.
What's number 2?
Homicide, often involving firearms and often related to gang violence or sometimes domestic situations.
And number 3?
Suicide. And this is a major focus for mental health screening. Suicide is the 3rd leading cause of death in this age group.
Okay, we need to deep dive on suicide assessment. What are the red flags? What are we looking for?
Well, depression is an obvious one, but look for regression. Withdrawal from friends is a huge one.
So they're isolating themselves.
Yes. Or giving away prized possessions. A sudden, unexplained drop in grades. Also, pay attention to high-risk groups. LGBTQ+ youth are at a significantly higher risk, not because of their identity itself, but because of the marginalization and bullying they so often face.
If we suspect something, what's the nursing action? Do we beat around the bush?
Never. You ask directly, have you thought about hurting yourself? Do you have a plan?
I know some people worry that asking plants the idea in their head.
That is a complete myth. Research shows that asking does not plant the idea. It actually provides relief that someone noticed. And if they have a plan, you do not leave them alone. You ensure safety. You remove lethal means pills, firearms.
Let's talk substances. Alcohol and drugs are classics, but what's the new challenger on the block?
Vaping. E-cigarettes. This is huge right now. A lot of teens think it's just safe water vapor. It's not. It's highly concentrated nicotine, which is terrible for that developing brain we talked about, plus heavy metals and other chemicals.
So the education is it's not a safe alternative.
Correct. And for alcohol, the big risk is binge drinking. Because of their physiology, high liver efficiency, high energy, they can often metabolize alcohol efficiently enough to stay awake longer than an adult might, leading to dangerously high blood alcohol levels before they pass out.
So they don't have the stop switch that adults might have.
Exactly.
Okay, that is heavy, but it's the reality of the ER. Let's switch gears to prevention. Part 5. Immunizations and nutrition. We're in the clinic. The 11 or 12-year-old comes in. What are we sticking them with?
This is a classic exam question and a critical public health moment. We call it the tween trio. At age 11 to 12, there are 3 routine vaccines due.
3 needles at 11. I like that mnemonic. Okay, what are they?
Needle 1, Tdap. That's tetanus, diphtheria, and acellular pertussis. No, the P is pertussis whooping cough. This is a booster to the DTaP they got as babies. Immunity wanes, so we boost it here.
Okay. Needle 2.
Meningococcal, ACWY, often called MenACWY or Menveo. This protects against meningitis, which is absolutely devastating in this age group.
Now, there is a catch with meningococcal, right? It's not one and done.
Correct. This is the exam trap. You get the first dose at 11-12. But you must get a booster at age 16.
By 16, why not? Like 18.
Think about what happens around 18. They go to college dorms, military barracks, crowded housing. Meningitis spreads in close quarters.
Ah, okay.
We want that antibody peak to be fresh right before they enter that high-risk environment. If you give the booster too early, it might wear off by the time they get to college. So, dose 1 at 11, booster at 16.
Got it. And the third needle?
HPV, human papillomavirus. This is the cancer prevention vaccine. Protects against cervical cancer, throat cancer, anal cancer, penile cancer.
And the dosing schedule here is tricky. It depends on when you start.
Yes, applying the Pareto principle. This is the complex detail you really need to memorize. If the child starts the series before their 15th birthday, they only need 2 doses.
Just 2.
Just 2. 1 today and 1 in 6 to 12 months.
So 2 doses, it's started before 15.
Correct. Their immune system is so robust at that age that 2 doses gives them full protection. But if they start on or after their 15th birthday, or if they're immunocompromised for some reason, they need 3 doses. Usually at 0, 1, 2 months, and 6 months.
So starting early saves a shot. That's a good selling point for parents.
It is. It's better immunity with fewer needles. And remember, HPV is not just for females. It is for everyone.
Is there anything else? What about meningitis B?
That's separate from the ACWY. Men-B is usually a shared clinical decision given between ages 16 and 23, with the preferred timing being 16 to 18. It's not strictly mandatory on every schedule like the trio, but it's highly recommended, especially for college-bound kids.
And obviously flu and COVID annually.
Standard maintenance, yeah.
Let's talk fuel, nutrition. They are growing so fast they must be eating a ton.
The caloric needs skyrocket. I mean, a teenage boy during his peak growth spurt can easily need 2,800 to 3,000 calories a day.
Wow, that's more than most adults.
It is, but it can't just be junk.
So what are the key nutrients we're worried about?
We call them the big three for teens: calcium, iron, and zinc.
Why those three?
Calcium is critical for the bones. They need 1,300 milligrams a day. Remember, nearly half of your adult bone mass is accumulated during adolescence. If you don't bank the calcium now, you get osteoporosis in your 60s.
So you're preventing fractures decades in the future.
Exactly.
And iron.
For females, it's obviously to replace losses from menstruation. For males, it's needed for the expansion of their muscle mass and blood volume. Everyone needs more iron.
And zinc.
Essential for growth and for sexual maturation.
We have to touch on the flip side of nutrition obesity.
Yes, roughly 20% of adolescents classify as obese. You need to be screening BMI. But the advice isn't go on a diet.
Right.
Diets in teens often trigger eating disorders. The advice is my plate. Make half the plate fruits and veggies, and focus on activity.
60 minutes a day, right?
Moderate to vigorous physical activity, 60 minutes daily. Sports are great, but you have to watch out for overuse injuries and concussions. And if they aren't into sports, just getting them moving, walking, dancing, even active gaming is the goal.
Part 6. Common issues. These are the things they actually complain about in the office. Let's start with the zombie mode. Sleep.
Adolescents are chronically sleep deprived. They need about 9 to 9.5 hours of sleep. They rarely get it.
Is it just that they want to stay up playing video games?
Well, that's part of it, but there's also a biological shift called a circadian delay. Their bodies physically don't start producing melatonin until later at night.
Oh, really?
Yeah, so they aren't tired until 11 p.m. or midnight. But school starts at 7:30 a.m. It's a complete mismatch between their biology and society.
So what's the nursing advice for that?
Sleep hygiene. New screens in the bedroom. The blue light suppresses melatonin even further. Consistent bedtimes, even on weekends, to avoid social jet lag.
What's social jet lag?
If they sleep until 2 p.m. on Saturday, they won't be able to sleep Sunday night, and Monday morning is a total disaster.
Got it. Next up. Skin. Acne. It's a rite of passage, but it really hurts their self-esteem.
It does. The sebaceous glands go into overdrive because of androgens. The advice is simple. Wash the face 2 to 3 times a day with plain unscented soap or a mild cleanser.
And the Gorvin rule?
Do not squeeze. Do not pop. It leads to scarring and infection. If over-the-counter benzoyl peroxide isn't working, get them to a provider, but don't let them perform bathroom surgery on themselves.
Finally, sexual health. We touched on the risk aspect, but what's the standard of care for education?
Education is the standard of care. Abstinence is the only 100% effective method for preventing pregnancy and STIs, and we should state that. However, we absolutely must provide factual, judgment-free information about contraception and barrier methods.
And consent.
Huge. We need to discuss what a healthy relationship looks like. 1 in 12 teens reports physical violence in a dating relationship.
Oh, wow.
We need to talk about consent, coercion, and that no means no.
We should also briefly touch on the concept of developmental red flags. We talked about what's normal, but what screams delay at this age.
Right. At this age, you aren't looking for not walking or not talking. You are looking for social and cognitive delays. A teen who cannot engage in abstract thought by late adolescence needs an evaluation.
Okay.
Or a teen who has zero interest in peers or exhibits no desire for independence. That might signal a developmental issue or maybe severe anxiety.
And what about age-appropriate activities? If you have a teen in the hospital for a week, do you give them a coloring book?
Maybe an intricate adult coloring book, but generally no. Age-appropriate activities for teens involve connection. Let them use their phone to FaceTime friends. Video games are great. Journaling. Anything that allows them to express their identity or connect to their peer group.
So isolation is the enemy.
Isolation is the enemy for the hospitalized teen.
All right, we've covered a massive amount of ground. We've gone from hormones to helmets. Let's wrap this up with our, if you remember nothing else, summary. I want the absolute highest yield takeaways.
Okay, here are my top 4 takeaways for the exam and for the bedside.
Number 1.
Safety first. The number 1 killer is motor vehicle accidents. Your assessment has to include questions about seatbelts, texting, and driving habits. And always, always asked directly about suicide. It's the number 3 killer, and silence can be deadly.
Number 2.
The 11-12-year vaccine checkpoint.
Mhm.
Remember the tween trio, Tdap, MenACWY, and HPV. And remember that HPV rule, 2 doses if you start before 15, 3 doses if you start after.
Number 3.
Regression is a red flag. It's normal for teens to be moody or want privacy. It is not normal for them to completely withdraw from friends, stop doing things they love, or have a plummeting GPA. That requires a mental health intervention.
And number 4.
Privacy versus safety. Respect their need for confidentiality to get an honest history. You need them to trust you, but know your hard line. If there is a risk of harm to self or others, safety trumps privacy every single time.
I love the analogy you used earlier about the bridge.
Yes. Adolescence is a bridge between childhood and adulthood. It's a long bridge, it's shaky, and sometimes the weather is terrible. Our job as nurses isn't to carry them across.
All right.
It's to make sure the bridge is structurally sound through vaccines, safety checks, and education so they can walk across it themselves.
And maybe catch them if they trip over their own rapidly growing feet.
Exactly.
That is a wrap on our adolescent nursing review. Whether you are cramming for tomorrow's exam or prepping for clinicals, we hope this deep dive helped you focus on the 20% that matters most.
Good luck studying. You've got this.
Thanks for listening to the deep dive. We'll see you next time.